Okay. Thank you, Maria. Hello, everybody. My name is Judith Dean. I'm chairing the session today. So I'd like to start by acknowledging the traditional owners of the lands on which we're all joining here today from the Emerging Brisbane, the Yagara and Turrbal people, and pay our respects to elders past, present and emerging. I'd also like to extend that respect to the lands on which all of our online participants have joined us from, and further extend that respect to our Aboriginal and Torres Strait Islander and other First Nations peoples who are joining us here in person and online. So it's my great honour today. We've got three of our early career researchers, sorry I've got my back to you online, here to present their work. On the invitation you had all their bios, so I don't think I'm going to read through all those bios for the interest of time. They're going to do a 10 to 15 minute presentation each, and then there'll be some questions. We might do all the questions at the end because I'm just a bit conscious that we're running a little bit late to start. Is three of you okay with that, wherever we are? Yeah, perfect. All right, so we've got Sarah, Penny and Stuart here to do our presentations, and that's the order we're going to do them. Okay. Over to Sarah. Yeah, you right?
Hello everyone, my name is Sarah and I have been working for UQ Poche Center for more than 2 years, specifically under this RAW project. So I'd like to present my seminar presentation on the research project that Research and Alliance Urban Growing Health, that is RAW project. RAW data linkage project is the first time research in Australia. At the beginning of this presentation, I'd like to pay my respect traditional owner of these countries and their custodianship and of the lands in which we made. We pay our respects to our ancestors and their descendants who will continue cultural and spiritual connections to the country. At the beginning of this presentation, I'd like to present about the RAW project. It's a collaborative research project of the UQ Poche Center, Metro North Health, Institute of Urban Indigenous Health IUV, and Queensland Health. And the main key objectives of this RAW project to understand the whole healthcare environment. It relates to healthcare pathways from the primary care to tertiary care or the vice versa. This RAW project also evaluates the current service delivery modes, co-design approach of the new services, programs and policies, building workforce capacity. Ultimately, it progressed towards the health equity and improve the health of urban indigenous people. So RAW data linkage project is the centerpiece of the work and center and core piece of the RAW data linkage project. And this is the data linkage between primary care and tertiary care of the healthcare pathways. That means the IUV and Metro North Health in the Southeast Queensland. The main primary aims of this research, as I said, that to link between IUV and Metro North data. Secondary aim will be to identify the patients who is not the part of the IUV but visited to Metro North, to identify them and link with the Metro North data. Third primary aim will be to establish, monitor and evaluate an indigenous lead governance system to ensure control, ownership, access and possession of the linked data set is appropriate. There will be some more aims and secondary aims, like to identify the cohort which visited to IUV and Metro North and to determine their descriptive characteristics. Secondary aim will be to describe their access and utilization of services in each services, that means in IUV and Metro North. Third, secondary aim to understand their healthcare pathways. That means they visited to IUV, then refer to the Metro North, then coming back to IUV or not, or they only visited IUV or Metro North only. Fourth will be to understand or explore the accessibility and effectiveness of this linking indigenous people's data to embrace the completeness and accuracy of the linked data set. This is a retrospective cohort study. So in that data linkage project, data from 2010 to 2022 will be linked to the Metro North data. all the healthcare records. That means all the indigenous people and non-indigenous people visited to IUA. That record will be linked to the Metro North Health data sets. And there are 11 data sources have been selected in this data linkage project. And among them, 5 of them are Queensland Health Statistical Services are their main data custodians, and rest of them actually external data custodians. In total, there are 5 data custodians for the 11 data sources. And Queensland Health Statistical Services will do the data linkage project. And there are 6 different research priority areas for the RAW project. In 2021, there was a workshop and all collaborators met and find out which research area should be considered for this RAW project. These are the 6 research area: cancer, mental health, surgery, rehabilitation, hospital in the home, and the maternal health. And when we are developing the protocol for the data linkage project, we met with the collaborators and find out 3 more research priority areas. They are emergency department, infectious disease, and geriatric and pediatric care. And during the data linkage project, probabilistic linkage method will be used for the data linkage project. That means the IUE identifiable data will be matched with the Metro North's identifiable data, and Queensland Health Statistical Service will do this job and create a project linkage fee for each patient. And so this will be the linked data set. And then I'd like to discuss about the research outcome. The primary research outcome, I said before, to link IUE data with the Metro North Hill data set. In case of IUE data custodian will provide the cohort data sets, all the identifiable information to the Queensland Health Statistical Services, and 5 data custodians from 11 data sources, they also provide their identifiable information to the Queensland Health data sources, Queensland Health Statistical Services. So this will be the primary research outcome. Secondary research outcome to identify and link Metro Health data sources. That means that the patients who directly visited to Metro North, not visited to IUE, will find it out that data cohort and link with the Metro North Health data sources. And Queensland Health Statistical Service will identify this cohort and match with this Metro North Health data sources. Finally, if we see our primary and secondary outcome, this is the whole data set figure. That means that if we see that the corner of the left side, that's the IUE data custodian will provide the data set, and at the bottom of the left side, Queensland Health Data Statistical Service will identify the second cohort, and they will match with the 11 survey total data sources of Metro North Health data sets. Secondary outcome primary third outcome will be to establish, monitor, and evaluate an indigenous governance system. As RAW research project is a collaborative research project, and at the beginning of this project, we have established RAW governance committee, and under this RAW data linkage project is under this RAW governance committee. And throughout this project, from the very beginning, we regularly communicate and seek their advice, governance committee's advice, to develop our research design protocol during the development of protocol, like research design, aim, research priority areas, which data set we should use, what type of data items we should select for this project, and governance committee advises us, give the approval, then we move forward. And this RAW data linkage committee linkage also part of the IUE data and research governance committee. They also time to time they also provide us the guidance and approval of this project. And now we are in the middle of the data linkage project. Actually, our plan in future to create RAW data governance and statistical analysis group. This group, main responsibility will be to monitor the whole data linkage project, where the data will go, where we'll keep this data, that means the storage facility, who can access this storage facility, who can control this data, how many researchers will be involved in this data linkage project. And in case of statistical analysis part, we'll try to understand what type of analysis we'll do for each research area. And whatever the research we'll conduct will be based on the research priority areas, and it should be aligned with the protocol. The secondary outcome was to create cohort and describe their characteristics. And as we said that if you think about at the beginning, primary outcome to link IUE data with the Metronode data. In case of IUE, we included all the indigenous and non-indigenous patients. So that means in the first cohort, we get two cohort, IUE indigenous patient and non-indigenous patient who visited to Metronode health data sets. And another cohort, we have found that they did not visited to IUE, directly go to the Metronode data set. This is the fifth number cohort. But I'm going to the next cohort. There may be a chance that patients did not go to the Metronode. They only visited IUE and get their treatment. So there are 5 cohorts we have found. So we will identify these 5 cohorts and try to understand their discrete socio-demographic and clinical characteristics, and these characteristics will explain through the age, gender, or public or the insurance status in that perspective. Secondary outcome to describe trends in access and utilization of services. As we said that people visited IUE and Metronode, actually in brief, it's only think about that only IUE and Metronode, but it's not only a one access. In case of IUE, they visited for so many reasons, for GP services, for mental health services, for care plans, so many other services. So we'll try to find it out that how many times they visited that services, and that because of the dataset link will be linked from 2010 to 2022. So we'll try to understand their whole mapping of all the patients. And in case of Metronode, when the people visited to Metronode, they directly access to Metronode like emergency department, or they access to the referral pathway. That means they receive the referral from the GP of the IUE, then visited to Metronode, or they receive the any other specialized care services in the Metronode. So in the secondary outcome, we'll try to understand that how many times they visited. Is it suppose in the emergency care they visited only 1 time, or in a year, or 5 times in a year. So all the types of access and utilization we try to understand. Third outcomes will be the healthcare pathways. If we see at the first outcome that people are visited to IUE, then go to the Metronode, then go back to the IUE again. That means after they get the discharge from the hospital, they have a discharge report, and they need to follow up to the IUE. So we'll try to understand, do they really go to the IUE or not? And secondary outcome will be like that way, that patients who visited IUE but did not visited to Metronode, what is their healthcare pathways? Where are they gone? Are they really only visited on IUE, and what is the reason? And third outcome will be probably they never visited IUE. These 3 healthcare pathways actually we'll try to understand, and we'll check it through the time series analysis. That means from 2010 to 2020, what is their pathway from that timeline? And fourth secondary outcome to explore the accessibility and effectiveness of thinking indigenous people's data. That means we'll try to understand that when they access the data, do they really timely access to the service or not? Suppose in case of surgery, when they get referral from the specialist, how much time did they receive for get the specialist visit? And how much time they get the referral for the surgery. Usually in case of the surgery visit, there are particular time period like 30 days, they may need to visit for the surgery. So do they really get this surgery or not? We'll check the mortality rate or hospital readmission, post-operative complications. Suppose after getting the surgery, was there any post-operative like adverse effect or not, infectious disease or not, or probably they didn't go to the IUE, they directly coming back to the hospital and readmitted again and go to the ICU. So all type of perspective, we'll check it out. And another thing, we try to understand that their follow-up, that means after visiting from the IUE or the Metronode, do they do the secondary visit or not, to their health checks, or how many times they visited, or they may not visit it at all. So this type of outcomes we'll try to understand in the fourth secondary outcome. This is the most important thing is that the data management system, and this is the part of the primary outcome 3 also, that when we receive this linked data set, where we will store this data set. And we'll store this data set in a key point, which is restricted with copying and printing out. That means that when we keep this data set, we can't print out any data set, or we can't download any data set. And there will be a vault manager who can control all the data sets. And if we need to download any data, we can only download the research output, and after the approval of the vault manager. So the first one here is actually key points. It's their data governance system, and second figure actually is I just draw it like that. We probably our data set like UQ Poche. Vault manager will control all the data sets, and there will be individual research activity, and each research activity probably will keep the researchers research priority areas of the data set, or whoever the people or researcher would like to do the research activities will separate in each folder and give their access. And if anyone external from this investigator team would like to apply this or would like to work in this research project, they would definitely go through the systematic process, like they would like to apply to the raw governance committee and IV data network governance committee, and then they would complete a concept sheet, and then the research project details, then get the approval, then all the normal procedure like it is approval process, PHA approval process. Current status of this project, actually last more than 1.5 years, I'm continuously working on this project. And if you see, all the collaborators are actively involved in this process, and UQ Poche team actually involved in throughout this procedure. And we received our ethics approval on 22nd of January, and PHA approval on 12th of July. So currently, actually, we are negotiating with our data custodians to transfer their data to the Queensland Health Statistical Services. After that, we'll keep the data in a key point storage system. And hopefully, we'll get our data middle of the next year. It will take around 6 to 8 months for the data linkage for the Queensland Health Statistical Services. Yes. And this is actually a very brief research presentation, but it's not that much very simple and brief. It's a very complex and a very elaborate process. And yes, and whatever the research primary aims and research outcome I presented, very simple I try to present, but whatever I try to check how many data items I selected, I found it out at least 350 data items will be linked with the Metro North Health data sets with the whole health records of IV data sets. So yeah, it's a first time research in Australia. Yeah, and yeah, thank you.
Thank you. And yes, it is a hard project to fit into 15 minutes, so you did really, really well. Let me just get Penny's presentation up. So keep your questions for at the end. So I've got the wrong one again, haven't I? All right, it's right in a minute. You got to drive the bus after all this time, wouldn't you? Right. Penny, where are you?
Well,
There we go. Yep, try that one.
all right, well done.
Is everyone okay? So I just sit down. And make it like a yarn. Oh. That's not sort of drying the slides for me though.
That is not good, does it?
Yeah,
And I promised Stuart I will keep to my 15 minutes. So if anyone is able to give me a bit of a signal, I do go over 10. When I get to 10, that would be great.
It's not sharing your slides at the moment. We're getting a black
Okay.
screen.
1 minute's gone.
No. It's gone. This is one of work.
Yeah, that one. Yeah.
Yeah, it's got just, hang on a second, I'll see if I can.
It's like if you add the
Next slide.
maybe go to the next slide.
Oh, there we go, got it working, right. You'll just have to go back, sorry.
Third one. Third one.
Right, that's right. Is it going the right way, Penny?
It's going the wrong way.
Oh,
Yeah.
there you go.
Yeah.
Oh, over to you. Or do you want to click it? Click
Legally, please.
Anyway.
it. All right, go.
Okay, thanks for giving me this really short segment. That's what I'll be talking about. I just want to acknowledge when I use the word maternal and women, I'm acknowledging pregnant people, female, non-binary. Thanks. Next one. And the acknowledgement. I acknowledge and celebrate the First Peoples whose unceded lands we meet on today and everybody online. So country, sea country, water country on which we live and work, and pay my respects to elders past, elders present, and extend my respects to Aboriginal and Torres Strait Islander people here today and our Indigenous colleagues. So that's who I am and where I come from. I grew up in the Rotorua area there, as indicated. I'm an Ngāti Pukenga woman. I come from a long line of fighters that might not come as a surprise to too many people around here, but I also come from a line of weavers, healers, and these are the way we told our stories and passed on our knowledges, right? Through our crafts, through our songs, through our stories, through our places. Okay. Just going to do a really, we've got Morgan online. Morgan's going to join us briefly to talk about bio. Morgan, are you there? Just to introduce yourself before I kind of do a quick run through some of the background. I saw you, Morgan. Do you want to do a quick intro? Right. Okay. Hopefully she's going to come in later. Right, so I just sort of wanted to, so that's who I am, where I came from. I wanted to do a brief run through about how I came to Poche, basically, and some of the things that I've worked on previously, because we're still at the early stages of our projects and don't have any data findings to present at the moment. But so from my MPH research, I was involved in research evaluations, maternity programs, including mobile health teams, health worker education, working with culturally and racially marginalised communities in Nepal, Cambodia, Thailand, Afghanistan. I drew on the wisdom of a lot of older women shared their wisdom with me, and I'll come back to that again. So I want to acknowledge them. Also, you know, just listening to these stories is where I started to get that more strengths focus. So, you know, going back a long time ago, we didn't have many Aboriginal people in our universities. This is sort of a journey about, you know, say how we got to where we are today. I'm going to stick to the script like Uncle Stephen says, so I don't go off too much. So what I really learned from this was the need to reorientate maternity care as well. So as you can see, care is provided in so many different contexts and those knowledges have been maintained. So that was shown my MPH and PhD research, but I just also wanted to highlight some projects that I was involved in during my PhD, and that's one of my most highly cited papers. It was just a sort of side project, but yeah, the value of getting those additional experiences while you're in that learning journey. Thank you. And just on impact. So, I mean, 15 years later or so, these were just recent articles about the mobile health teams that I was led the evaluation for, and that was a major policy that was taken up in Afghanistan and still continues, albeit under obviously challenging circumstances. And Bangladesh, I've had the privilege of working briefly on an evaluation there, where there was a commitment to midwifery education and rolling that out. So that was another experience during my PhD. So you can see why it took a while. Thanks. And then so postdoc, I went over to the UK where I have some ties on my mother's side. And so I had the opportunity to work with a team looking at increasing, obviously, the equity in antenatal care, working in the super diverse populations of East London, and on methods some of you might be surprised as a qualitative researcher. I actually did work on clinical trials and cohort study as well previously, but this also and that's gone on to a full trial actually, just to point out, working in a large NHS trust over there. So that was also an experience in all those levels of bureaucracy. But the impact and effects of institutional and interpersonal racism, intersectionality, language, class, where people live, citizenship, migration status, etc., was something that I really learned from this experience. And really, I think, started to develop ideas around anti-racist practices for myself. Yeah. So thank you. Next one. Briefly, science communication project, which also was a great experience for how we communicate complex ideas and try to break them down into plain language to bring people along with us, and worked with an amazing team, mostly based at Sydney. As you can see, other partners there. Next one. Okay. So then I had, the amazing experience of the opportunity. So it's only 5 years ago now to move down to Yuin Nation on the south coast of New South Wales, and worked with an academic team there, as well as being embedded within an Aboriginal community-controlled health organisation, which was a women's organisation, an amazing deadly women's organisation that's just women is just about to celebrate 40 years. So Birthing on Country, for people who are unaware, is a First Nations designed and led model of care. It's a birthright, but it's become a birthright, right? That's just the way it is at the moment, unfortunately. So as you can see, we also had to learn to break down our work for politicians, members of parliament, in these kind of briefs, and advocacy, use our research for advocacy. So, politicians, obviously have not a short attention span, but have a limited capacity to, process research findings. So again, that was a really great learning experience there. I also learned about the intersectional barriers at community level for ARCHOs, Aboriginal and Torres Strait Islander community controlled health services. The hoops that they had to jump through. But Waminda was amazing, as you can see there, effective at lobbying. We were in a marginal seat and managed to secure money to, what's going to be just an amazing, just an incredible birth space for women there. And, we're confident that it won't be just for First Nations women. I mean, obviously that's the main objective, but that other women also will want to come there. Thank you. Next one. I'll just... got some findings forthcoming from that one, so I can't give too much away on that, but listening to the experiences of women, I think, is what, and as I mentioned, the services, the process of developing the models. But I mean, for me personally, so this was just, it sounds trivial, but like a life-changing experience for me. I had the opportunity to come into the space, participate in ceremony, and I think that's where I first developed a trauma-aware and trauma-informed and healing-centred approach. And I had the opportunity to really learn from, again, wise women. And, our stories are central to our experiences. And for me, I connected back. Now, this is a work in progress. It may not be right. I'd love to have conversations with people about some of this. But these are some of the concepts. We were talking about our values before. as a centre. And some of these words from my language were coming up because they encapsulate, all the things that we're trying to capture into words as an Indigenous centre. But yeah, I really understood, say, our stories and our processes and our learning, our knowledges in a really different way. But fundamentally, those connections with our community. And there's only one word up there, but to a translation of these words, but they encompass a whole, concept. And so, yeah, I really started on my learning journey. In some ways, it was a rebirth for me, being in this space. And that's obviously what this beautiful country was like. And during the COVID pandemic, I spent a lot of time where I had the opportunity to obviously weren't allowed to have gatherings and things. So I spent a lot of time out there just walking country and listening to country and thinking, what am I supposed to be learning? What was it that the ancestors wanted to teach me, on this space, in this space? And so now I also acknowledge AI. This AI has contributed to the seminar. It's some ancestral intelligence. So I've moved forward. Thank you, Leif. So is Morgan?
Yes, she's here now.
That's Morgan. Hi, Morgan. Hello.
It's been resolved.
Hello.
Oh, thank you. You there?
Hi, can everyone hear me?
Yes.
Oh, great. Hi, everyone. My name's Morgan. I'm Broadhurst Hill. I'm a proud Bundjalung woman, and I get to work alongside Penny and Judith in the room on the lovely BIOC Birthing Our Community space. So a little bit about me. I've got a Bachelor in Public Health and just recently completed my postgrad in Indigenous Health Promotion. And then this is Keely, and I get to work alongside Keely as well. She's also a proud Indigenous woman from New Zealand, and she has a Bachelor in Science, majoring in Public Health. So we are the research assistants that get to yarn and engage with community in the BIOC community space, and we're very fortunate to work with you guys at UQ Poche.
And so, yeah, so overview there.
So we have the two studies here. We've got the Lewis study and the Deadly Fit Mums study. So the Lewis study is a longitudinal study, and basically it's about evaluating the clinical outcomes, so the acceptability, feasibility, scalability, and sustainability, and the impact of BIOC across the 4 different sites in Southeast Queensland. And from the study, we look at the 4 different time points, which is quite interesting. So we look at the antenatal at registration and intake of our mums. And we yarn to them and hear about why they've come to the BIOC program. And then we have time point 2, which looks at before birth. So we got the 30 to 36 week point. And again, we yarn with them and engage and look at their expectations and experiences so far. And then we have time points 3 and 4. So this is postnatal after their birth. The first kind of looking at that 4 to 6 month mark after they've given birth. And then the 4th time point is looking at the 12-month mark, and we get to yarn with themselves and the bub and seeing how they're going. And then we also get to yarn with the family as well. So that's really cool to be able to engage with them and hear about their experience through the BIOC space. So we've got some aims, and that's, obviously to engage and look at the expectations of the model. And we're looking at gathering the pregnancy and the care journey experience, looking at the birth and the care and the early baby stage. And then again, seeing what it's like as a parent and that family story and really capturing that. So the recruitment for this is 15 mums at each of our BIOC sites. And then at that time point of 3 and 4, it's 10 mums. And we also get to yarn with the staff as well. So we're looking at that implementation and that scale up of the site and the program. And so approximately 10 staff we are yarning to across each site. Yeah, so that's really the Lewis study, and it's pretty cool. And then we switch over here to the Deadly Fit Mums. So this one is for looking at the health outcomes for our First Nations babies and their mothers. And this is looking at the Greater Brisbane region. This is a lovely qualitative study. It's looking at birthing and people and their families, and looking at the engagement and participation and their perspective of the program. This only has 2 time points, so we get to yarn with them at registration, and then we get to yarn with them at the end of that program once it's completed. So there's 10 mums that we are engaging with across the 4 different BIOC sites. And then again, we get to yarn with the staff and get to learn about the program itself, the strengths and the challenges. And then we engage with them and see, what are the recommendations and improvements going forward with this program. So there's 15 staff that we'll yarn to over each 4 sites. Yeah, that's kind of the studies. Thank you.
Thank you so much, Morgan. Lovely, thank you. So yeah, have a privilege of working, as Morgan said, with the team there. Just also to acknowledge that there is a quantitative to the BIOC and Deadly Fit Mums, and I'm sure you'll be hearing about that in the future going forward. So Fedi and Tamina leading that space, and also an economic evaluation as well. So just realise that my time has largely gone, and these are just some, values, principles, ideas, as I said, bringing all of that together about some of the areas where I'm keen to, hopefully with some partners, as with IUE, to develop more research and better understanding around what our community are experiencing and what their needs are. So I guess looking on the teaching and learning side and the research, but how our teaching and learning integrates with our research and with our organisation partners. And yeah, essentially, I guess the dilemmas that come up for me are the relationships versus the products, and say keen to have more conversations in the future when we have time and space. Ownership of research, individual versus collective, like collective authorship models. How to write, submit, get funded a strengths-focused research proposal in a problem-centred world, I would call it. And establishing, diminishing the experience of having diminished the academic credibility of First Nations knowledges, ways of knowing, being, doing. So always those tensions, I find, and moving in those spaces is always a challenge as a researcher in a wide academic space. And then just finally, I'm also interested in like the whole reproductive life course, obviously politics aside, but obviously women's bodies are political. But also in the Indigenous space, a resource is not a lot of work around that's been done around the change, and this was only literally a resource that like last month came out. There is a grant open at the moment that does include menopause, and I think it's probably on the back of the Senate inquiry that's going on at the moment, so there's a potential space. And also just trying to be sensitive and open up the conversation, but the Centre of Excellence that's been established, eliminating violence against women, just a little bit of a plug, they've got 2 PhD projects open there that are around the Indigenous space, and something that's been coming up in discussions with our Māori and Pacifica community recently. And, so it's understanding women's issues that affect men and men's issues that are affecting women. So I just really would like to open up that space at some point when it's appropriate, if possible, to really try to improve, the situations and support, obviously, communities under stress and focus on the strengths. You know, there's amazing things that are being done out there in families, and just being able to get that story out and counter some of those negative media. And yeah, so thank you, Morgan, and yeah, thanks everyone.
So our last speaker, Stuart, you're, have you got a slideshow or are you?
I've emailed them to Sharon and Maria and
Did you send a Poche on Sunday or?
to Dina and
Submarine.
Maria and Dana.
There, sorry, everyone, we'll just get Stuart's slideshow up, and apologies for running a little bit late. We do have lunch after this, I believe, provided upstairs on 4. Yes, 4.
Not sure whether it's
Somewhere,
here or-
somewhere it's provided, so we can have I think a good question time and yarn then, hopefully over lunch. Then we're running a little bit late. Blame the facilitator for poor time management or techno issues.
Dana be able to share? Is she online?
She is online.
But yeah, this is enough.
There's nothing in here. Donna, are you there? Can you save me?
Second slide.
Sorry, but I'm not sure if I can share it. I'm just trying to figure it out.
Your slides are coming up blank.
Yes, there's nothing in the attachment that that you sent me.
I'll go and make one.
Can you plug your lap?
Any questions for the?
Yeah, maybe some questions while we've got time for the other two speakers.
Yeah.
Anyone online, just pop your hand up or pop in, or anyone in the room, questions for Penny or Sarah while we wait. Or Morgan. Yes, sorry, Morgan. My back's to the screen there, sorry. Any other questions?
Can I go with the raw project? Yeah, so for the raw projects, I have two questions. Like, for the data source, you mentioned the non-admitted patient data collection and admitted patient collection. So I'm not sure whether I missed, you have the EDC data collection, like the emergency data, if it is, and then it's okay. And the second question for me is like that you have like the wide source of data, like 6 research topics, like in terms of future plans. So do you have anything in mind, like how we can have a data sharing plan in terms of like, suppose I have the very good intention of the maternal health research, and then there is some cross-cutting issue, the data set that we have been looking at the metronome, like the bio space, that we have some data sources that we are looking for 2013 to 19, that we need to go for the separate PHA application. And then you already have the PHA been approved and you got the data from there. So whether there could be a possibility, considering that we have some investigator in our team that's also common to your team, like James. So whether we can have this data made accessible to us or not. As I said at the end of the presentation, that if any external researcher would like to do that raw research project, they have to follow the procedure, like they have to apply through the raw governance and statistical analysis group and submit the concept sheet, research proposal, everything. Then this proposal will go to the governance committee. They will check all the investigative team, all the research project, all the research outcomes. If it is aligned with the protocol, then it will improve. If it will not align with the protocol, then you have to apply for separate application, and we have to submit the application to all the data custodians, whatever the data you like to take. So you have to go through all the procedures, then you can get access. And it's not it's possible, but little bit time. But yeah, that's like the things making a balance, like whether the going to the PHA is less time consuming considered to going to the raw governance. But at the beginning, you have to apply through the raw governance committee. Okay. If they approve it, then you have to pass through other. Thank you.
Great, thank you. Just an update, Stuart's actually having trouble with we're all having trouble with the PowerPoint. There seems to have corrupted, so we can't open it. So we'll hold Stuart off, unfortunately, to another day. So we do have some time now for questions from the floor and people online for Penny and Sarah. Or even just some thoughts around some of Penny's suggestions around future research. Alan?
Oh, I was just going to ask another question, Sarah. Sorry, putting you on the spot. So with the key point storage, so I assume from what I understand with a linkage, it would be completely de-identified to start with.
Yes,
Yeah, and it would have like the linkage key would be the project ID
Yes.
or something like that. Yeah, yeah. So all the data that sits in the vault is by definition de-identified.
Yes.
Yep.
Yes.
Okay.
Thank you.
Do you want me to answer that question?
You can make comment on the question in there. Do you want to read now? You can.
Thanks, that's Amanda, is that your question? Thank you. Yeah, look, I think that's definitely the hard part, isn't it? And it's the work in progress. I think just, you know, even reflecting on a conversation that Morgan might be able to add to this, the Aboriginal and Torres Strait Islander community controlled organisations that we've been working with already have that in place. It's embedded. And I think so by the research sovereignty being with them, so governance, leadership, all the systems and processes and is led by IUE, our partners. I think, yeah, that's there. I mean, yesterday we were just having a conversation about when people share about the traumatic births, and unfortunately that's not unusual when people are birthing within the mainstream maternity system. So yeah, those reflective process and support processes are already embedded. So it's not, you know, anything that we need to add on to that. But I think having like Morgan and Keely in the space and, you know, leading the research and we're just kind of the outside technical support, you know. I don't know, Morgan, have you got anything you want to add, or if not, that's fine. But yeah, I'd love to hear your ideas, Amanda, and yeah, other people.
I think today we've had two examples of some quite complex studies. The first one, very complex, and having worked in multi-site governance agreements with Queensland Health, hats off to you, Sarah, and the team of RAW for getting it this far, because that is an incredible achievement, getting all those PHAs and agreements in place and still being upright and breathing and able to present it. And Penny for another, you know, journey through your research career and an example of a complex research study at the end with obviously multiple phases of a qual arm. But again, we've got the whole quantitative arm as well, which we will hopefully, with the qual, be able to really give some nuanced community-led understanding of the experiences of mum and how the models can be further developed and enhanced and expanded here across Southeast Queensland within the IUE model, but possibly as a scale-up product that could go out broader for the urban context, because a lot of the birthing now on country programs are more regional, remote settings. So this urban context is a different area where this birthing in our community project is a different model and context. And so really interested to see where the further expansion could go with that. And wouldn't it be wonderful to have a women's birthing centre here as opposed to also down in South? So all options where hopefully the research will be guiding and informing in partnership with IUE, who are the providers of that model. If we don't have any other further questions.
Probably if I have 5 minutes time, I can talk with
And maybe not 5 minutes, maybe 2.
No, maybe 2, okay, whatever the course will take time. Actually, I've been here since 2022 June, and actually it's so much complex project. At the beginning I didn't start it. Luckily I have done a little bit of literature review and published the articles, get some idea and understand what is the healthcare system, what is the access means, what is the utilization means, what is the utilization of service and the healthcare pathways. Then I started this project, and this is so much complex projects. We means me and James, actually. James, actually communicate with all the collaborators, all the IB team, investigators team, all the Metro North teams. It's not only the Metro North team or one or two people, it's a different Aboriginal Torres Strait Islander leadership team. I acknowledge their contribution of this project. Time to time, they gave us the comments, feedback. We organized a meeting, get their feedback, put into the protocol. All the sentence in the written in the protocol, it doesn't mean that we are coming by written this only one or two people. We took the advice and understand what is their concept, what we have to do, what we have to do in future. Another thing is that we have to negotiate with the data custodians. Every time I have to answer the question, why do you need this data? What is the purpose of this data? And it was very hard to make them understand. Still, few of the data custodians, like I can say that notifiable disease conditions one, it was very hard one. I could not convince properly that team to get all the data, but the rest of the data custodians is obviously helpful and give us the data. And I don't know how many PhD application draft I have. I have prepared to communicate all the peoples. This is a very complex procedure. And at the end of the project, I said that we get the data at the middle of the next year. It doesn't mean we are stopping our project and we are not doing anything. In the meantime, we have to go through so many processes, like prepare what is the concept sheet and the statistical analysis plan, what is the governance committee will look like, how can people access the data, who will get the permission, and everything we have to think about, and we have to convince our collaborators and everyone. So actually, it's not a 15 minutes or half an hour or 1 hour presentation. It's about actually more than that. And thanks to everyone, this is the first time I'm presenting it here, and people will get some idea about this. And thank you, James, for helping me out actually.
Just to kind of, the scale of that linkage
Yes.
is huge. So there are 28,000 patients at IUE, Aboriginal. And there are 5 major hospitals in Metro North.
Yeah,
So it's
yeah.
Caboolture,
Royal Brisbane,
Royal Brisbane, Prince
Yeah.
Charles, Bexley.
Stars, yeah.
It's a very big linkage. And so find out the whole point of RAW, the body, is to understand the pathways, not look just at community control, but look at mainstream as well, and the interaction for our people between the two. And that's the only way we can kind of work out how to do that
Yes.
is through linkage. And so it's a very big study. Most people will link the cancer database with another database, and that's it. But we're linking 11. So it's an Australian first to link everything, and then and it's over a 12-year period. And so there's going to be a lot of data there, and there'll be lots of student projects and lots of data analysis work to be done with all the different data sets in there over time. But it will be able to, the thing that we're really interested in, where does the mainstream system do very well and where does it not do very well? And how do we improve the system there? Because I think the community controlled services do pretty good at looking after our mob, but the mainstream services, we're not, they're under the radar because there's no microscope on them. And so really trying to put a microscope on what happens in the hospital system for the First Nations people in Southeast Queensland. So it's an exciting project, yeah. And Sarah has worked incredibly hard. Yeah.
Thank you.
Thanks. And be careful what you become seen as an expert in, because no one will be coming to you to help with the PHA. So forewarned. So thank you, everybody, and apologies we couldn't have the third presentation. We will get that scheduled into the follow-up ones. We've got 2 more of these sessions this year where our ECRs will be presenting, and we would like to make that a regular occurrence within the seminars. So not that I'm watching anybody or looking at anyone, we'd like to set that up as we move forward to share our work internally and externally with our partners who join on. So thank you everyone for joining online, and apologies for the technical issues and the slight delays. Please send through any questions, via email to either of the speakers as well well. I'm sure they'd be happy to answer any questions that you didn't have an opportunity to ask now. And welcome and join us for lunch. Where it is, I'm not sure, but we will find it. If you're hungry, you'll find the food, I'm sure. Thanks, everyone.